Today it'll be available on YouTube, there'll be links on our website, things like that. So I will attempt to speak into the microphone, and if we have any questions, somebody will come around with a cordless microphone. Apparently they already have the cordless microphone, because I don't see it, and just so that we get your question on tape and we don't have to repeat everything. So, Rich, somebody want to get that door? That door? And Rich, can you get the lights? All right, well, thanks everybody for coming. This is a very good turnout for one of our events, and I think that reflects the interest and concern there is about healthcare reform, not just in the country, but in our client base and in the community. We are going to try and be fairly comprehensive. Healthcare reform is actually a very broad subject matter. A lot of things you're not even convinced. If you could leave that door open there in the back, on the left, Jared. Yeah, leave that one open, so the people. Well, okay. Well, fine.
That's where the door is if you need to duck out.
Hopefully there won't be anybody out there during the session for too much time, or else they're not paying attention. Yeah, you get a little more light in there, Rich?
Hang on just a second. Somewhere in between.
Okay. Too far. All right, I thought we had these buttons worked out. Yeah. Okay.
That'll stay for us.
Let's see. Can you still see the slides? Okay. Thanks again. Just a few introduction comments before we get going, a little housekeeping. There is no cell phone reception down here, generally speaking. The lights will keep going up and down until somebody figures out how to work that. Yeah, we thought we had the settings preset, but you push the button and then they have a life of their own and they go to whatever setting they want to go to. And apparently it's not the setting we're looking for. But this should keep you up anyway. For a while. So anyway, the restrooms, when you walk in the front door, you made a left to come in here. Had you made a right, that's where the restrooms are. If you need to leave the room for any reason, including getting more food or beverages, because that'll be open the whole time, preferably you'll use that back door over there, because this one makes a lot of noise when you go in and out, plus it's kind of distracting. So if you can use that back door, great. We do have Wi-Fi down here. Some phones work on Wi-Fi. If you want to surf the web while we're talking, there's the information you need up there. There is a phone in the lobby. You dial 9 to get out, but there's only one phone, so if anybody still knows how to use one of those phones, where you pick it up and dial a number. No phones room. Okay, and feel free to help yourself to food and drink. We've got a lot more than we need. For those of you who don't know, I'm Kevin Steele. I'm Chief Operating Officer and General Manager of National PEO. For those of you who don't know who National PEO is, and some of you saw this advertised in the Business Journal or heard about it from somebody else, we are a professional employer organization. Basically, we are a one-stop shop for employer-related services, payroll, human resource consulting, human resource compliance, employee benefits, both procurement and administration, which is why we're involved in healthcare reform and why we're putting on this presentation. We also have a insurance company, Nexus Partners Insurance, which sells all kinds of business insurance. It also sells, of course, health insurance. We also do individual home and auto and individual health insurance now. So we can also take care of your insurance needs. Dave Dotson back there is our P&C guy. Hans Olson is our health insurance guy. If you have any questions during the presentation, if you can hold it to the end of the section, that's great. If it otherwise is something that should come up and we need to discuss right away, that's fine too. Put your hand up, and I'll send Kevin Johnson here, just to confuse things. We're both Kevin. He will come to you with a microphone. That way we don't have to repeat all the questions, and it'll get on the tape. We're hoping to wrap up by 11 o'clock. I don't think we're going to have a big problem with that. Because we're taping, we are going to have to switch tapes at some point, so after 58 minutes, I anticipate we'll have a short break. Other than that, if you have questions and you want to hold them to the end, that would be great. I will be here. All the National PEO people will be here. Tracy Miller from Ogletree Deacons will be here after the meeting. Hans will be here after the meeting. Everyone will be here after the meeting. So if you don't want to ask the question out loud, you can certainly wait till afterwards. Okay, are we good? Is this where the lights are staying? Okay. Okay, a disclaimer to start. Healthcare reform is constantly changing, and we had regulations came out last week pushing back a deadline on the earliest implementation requirement of healthcare reform. So now we have a few more months on that one. But I'm just going to read this to you so I don't have any legal issues. Healthcare reform is still evolving and subject to change. What we will tell you today is correct to the best of our knowledge at this moment, but is not a comprehensive discussion of all aspects of healthcare reform. We are not giving legal advice, not even Tracy, the attorney, is giving legal advice. Certain explanations have been simplified for understandability. There will be exceptions to many of the provisions we explain. If you are a National PEO client, you can contact us for assistance with any aspect of healthcare reform. If not, please contact your legal counsel or your CPA or your health insurance carrier or somebody who knows what they're talking about. Okay. I'm not sure what those numbers are doing there. Hopefully those numbers aren't going to be there forever. When we say healthcare reform, we're really talking about the Patient Protection and Affordable Care Act, sometimes referred to as Patient Protection and Affordable Care Act of 2010. That's because President Obama signed it on March 23rd, 2010. It went into effect 6 months later on October 23rd. Various names for the same thing. Obviously, it goes by its initials. It goes by Affordable Care Act. It goes by Healthcare Reform, which is what I generally call it. And, of course, we all know Obamacare. While we are going to be concentrating on the 2014 impacts, those are the ones you hear about. Those are the real significant changes that really affect how health insurance operates in this country. There have already been lots and lots of impacts of healthcare reform that not everybody appreciates. One of which is a couple years ago, you could no longer deny coverage to someone if they were under 19 years old, or someone on your policy was under 19 years old. If they had a pre-existing condition, you could no longer not offer them coverage. As you'll see going forward, that whole issue, pre-existing conditions, you won't be able to deny anybody coverage going forward. As you probably know, if you have adult children under the age of 26, they can now be covered on their parents' policies. There used to be lifetime dollar limits on policies. That, of course, would be horrible if you had some chronic disease and one day you found out your benefits ran out. Well, they can no longer do that. They do still have annual limits, but those annual limits have been raised over the last couple of years to what is now $2 million. And in a year or two, they are expected to completely go away. Those of you who are familiar with the Medicare donut hole, that was substantially closed. Preventative services with no cost sharing, if you went in for a physical or colonoscopy or a mammogram or something like that, you used to have to pay your co-pays. You no longer have to do that. There's the small business tax credit. That's been in effect for a couple of years. I don't know if anybody here has taken advantage of it. But if you are an organization with fewer than 25 employees and your average compensation is less than $50,000, then you may qualify for a tax credit towards paying for your health insurance coverage. There's such a thing as a summary of benefit coverage. Most of you haven't seen this yet, but starting in the fall of 2012, insurers are required to issue what's basically considered to be a plain English or easy to understand description of how your benefits work, and that needs to go to every participant in a plan. In fact, I think it also goes to eligible people, even if they're not participating. Used to be you could put over-the-counter medications on your FSA, HRA, or HSA. That's no longer allowed. Minimum medical loss ratios went into effect last year. Those of you with health insurance plans, a lot of you, if not most of you, would have gotten checks back from the insurer. That's because under the minimum medical loss ratio regulations, the insurers must put 80% for small group and 85% for large group of the premiums they collect into patient care or the payment of claims, as opposed to administrative costs. So there was obviously a feeling that the carriers were wasting too much money, and that was what was one of the reasons for healthcare being so expensive, so they limited how much they could make, basically. Small business wellness grants, if in the interest, and one of the objectives of healthcare reform is to try and reduce healthcare costs. It doesn't really do that in the short term, but one of its objectives is to go with preventative rather than reactive type medicine. So the government you may be able to qualify for a small business wellness grant if you want to put in a wellness program. These are legitimate formal wellness programs using third parties that come in and evaluate body mass index and stuff like that, and look at who has healthy lifestyles and who doesn't, put you through programs to help you change your lifestyle so that you're healthier. You may be eligible if you want to do something like that for a grant. You have to be less than 100 employees. There is now a rule that you have to give 60 days advance notice if you make any material changes to your health insurance plan. If you make those off-cycle. If you make them at renewal, you don't have to worry about it. But if you decide halfway through the year that you're going to change the waiting period or eliminate some kind of a benefit, you have to give your employees 60 days notice. Women's preventative services with no cost sharing, that came into effect starting this year. So if you're accustomed to doing those kind of things and having to pay money for it, you no longer have to. There's a high earner tax that we'll talk about a little bit later. There's a withholding and even a non-wage income or investment income tax that'll go into effect this year. FSA contributions have now been brought down to $2,500 a year. If you're in the National PEO FSA, not to worry, we were already at $2,500. Oh, sorry, we're at $2,000. W-2 reporting of healthcare costs, very few of you are affected by this. You're only affected if you had 250 more W-2s in the prior year. We had, of all our clients, hundreds of clients, we had, I think, 4 or 5 that actually hit that requirement. And that's W-2s, not employees, so if you had a lot of turnover, you could hit that. Again, if you're a National PEO client, we took care of that for you. And then healthcare.gov, the government put out a website to answer all your questions on healthcare reform, as well as questions on healthcare in general. I've never been on it. Mr. Johnson here has been. He says it isn't that good and it isn't that easy to understand. So I can't recommend it based on his experience. Now Kevin Johnston is going to talk about what's going to happen in 2014 and beyond. It is where we're going to concentrate, and I'll turn it over to him.
Ready to go. Good morning, Kevin Johnston. I'm the Director of Benefits. So between myself and the other couple people here in my department, who are John and Katie, if you'd raise your hand or even stand up or something. So if you've dealt with benefits and you've worked through us, you've probably talked to one of us. My department makes sure that the policies that our customers have in place work for them. We help with interactions with the carrier, claims issues, billing, all of those different pieces. So let me give you just a couple of quick points before I delve right into the slides. If you didn't grab a copy of the paper slides, you're welcome to get one on the way out, and we can also email this to you electronically if you'd like it or if you need to be able to share it. All right. No one knows all the answers in health care. Not even for plans that already exist, because they typically vary by state, they vary by carrier, then by the different plan design. And now we're talking about what might happen or is likely to happen in 2014. If you can imagine, I view this whole healthcare reform conversation, you ever seen 3 people trying to dance together? Little awkward. Here's the 3 people in my estimation. You've got the government, and that's made up by different entities that you're familiar with, like Department of Health and Human Services, the Department of Labor, the IRS, as well as the different states. Another person you've got to consider is the carriers, the health insurance carriers, Aetna, United, Blue Cross, with the reality that as they decide how to offer their plans, they're not going to offer a plan if it's likely to lose them money. So they're always rebalancing and refiguring, okay? And then the final dance partner is the end user, the consumer, whether that's an individual or whether that's, the company looking for a group plan. So basically one entity makes a change and then the others react, and we're still going to see how it all balances out. That being said, we are likely to have some changes even to what we're presenting here today before things actually become official. But of course, we'll keep you posted on anything as it changes. One thing that I've learned in my 34 years on the planet is you've got the rules and then you've got the reality. So think about speeding. If you're on the freeway, you're probably not supposed to go over 65, but I know my car can do that. If I drive around going 90 miles an hour everywhere, pretty soon I'm probably going to get a ticket in a few days, but I can probably do 6, 7, or 8 miles an hour over the speed limit. And that's probably never going to have a consequence. So the reality is, as these laws, these regulations kick in, what are the consequences? Do they have any teeth? Who's going to enforce them? Those are the other kinds of concerns that we're also keeping in perspective here. The rules versus how does it actually play out realistically. Okay, so moving on to what do these plans have to have? Coming in 2014, they have to have what are called essential health benefits. If it's going to be a qualified major medical plan, which is really what we're dealing with, overwhelmingly it doesn't affect most of your ancillary coverages, things like AFLAC, et cetera. Really, even dental and vision are likely to go unchanged, except there's one little wrinkle I'll tell you about kids. But preventive and wellness services we already talked about a bit. Chronic disease management probably makes sense. Prescription drugs, lab services, blood work, et cetera. Ambulatory patient services, little confusing, doesn't actually mean an ambulance ride. It means your ability to amble, to walk into a business like a doctor's office, an urgent care, et cetera. Has to include emergency services, hospitalization, rehab services. So you hear both rehabilitative and habilitative, but basically something happens to you and this plan helps you get back to 100%. Maternity and newborn care. Pediatric care, we're looking to see how this plays out because it's now a major medical plan, when it covers kids, is supposed to include elements of oral and vision care, more than you're used to seeing right now, a basic, look at the E on the wall. So mental health and substance abuse disorders. Some of you with groups of 51 and higher may have already seen this affect you, what's called mental health parity, saying that you have to treat individuals dealing with mental health issues the same way as physical traditional coverage. So what this law will impose is that you have to have a balance, a parity between both physical and mental health. One little note is that there are things called self-insured plans, and I will leave that conversation to Hans, who is our senior broker on the health side of the conversation. But if you have a self-insured plan, there are certain elements of healthcare reform, including the essential health benefits, that aren't as stringent. You have more flexibility with exactly how your plan runs. If you're self-insuring, basically you take the premiums and then you pay the claims yourself, is the general concept of self-insurance. Currently, National PEO doesn't actually have any of our small and mid-sized companies who are on a self-insured plan, but people are looking more that direction. All right. And all this tells us is that if you have a renewal as of January 1st, or you're starting a plan on January 1st of 2014, these pieces have to be in place. If you've already got a plan and it renews, let's say March or June, whenever, in 2014, only upon your renewal date do the new mandates for essential health benefits have to be there. Okay. This is a little different than what you're used to seeing if you're familiar with some of our terms that we use in insurance. So you all know deductible, the money that you typically pay first if something big happens. You've also got copays for your most common sourcing of care, like a doctor office copay or a prescription copay. And then co-insurance, after you've met your deductible, the slice, the percentage that you pay until you reach your, quote, out-of-pocket max. Well, they're changing the way that this is calculated because right now, copays overwhelmingly continue indefinitely. So even if you've had a giant claim, if you're still going to the doctor over and over, you still have a doctor copay every time. In this case, they actually include the copays with these figures. So what we're saying is, worst case scenario, you get cancer and then you get hit by a bus. Any given year, you shouldn't be spending more than $6,250 for an individual, twice that for a family. Underwriting. So we see this a lot right now as we try and help find group plans for our clients. Here's the current process. Medical underwriting, especially for groups with fewer than 25 participants, they have to fill out a medical questionnaire that tells about, they have these heart conditions and they're taking these prescriptions, height, weight, etc. It's going to check out their pre-existing conditions. It's based on their gender. Young males are cheaper. Older males tend to be the most expensive because we get into heart attack range. Tobacco use can be figured in. Location, where you are, your claims history. There isn't what's called guaranteed issue, at least not in the individual marketplace. If you're an individual with a pre-existing condition that's scary for a health insurer, they don't have to write you coverage, at least not in the state of Arizona right now. In small group, they do have to offer you coverage, but they can max rate it where it's essentially more expensive than really makes sense for anybody. So that is guaranteed issue. And SIC code, basically the nature of the industry that you work in. If you're a tree trimmer, you're more likely to have accidents which could result in claims. Coincidentally, if you work in the health care industry, like if you're a doctor's office, the health insurance carriers figure you're probably a little savvier about how insurance works. You might be able to take a little better benefit out of that plan, get more bang out of their claims costs. So they actually rate up doctors' offices, which you would think everybody's keeping themselves healthy. But SIC code does factor into your rates right now. So in 2014, age can still be considered when you're determining what someone's rate would be. However, it can be at a factor of no more than 3 to 1, which means your youngest person, their rate, then moving to the oldest person can't pay more than 3 times what that youngest person pays. So essentially, the reality is the younger people are subsidizing the older people. All right, location, which is to say, depending on where you live in the U.S., healthcare costs more or less. It's less in Kentucky than it is in New York City. And tobacco use. So they can still ask, do you use tobacco? It's a relevant factor that they're allowed to include in your group cost, but it means that for a tobacco user, they can't be charged more than 50% what a non-tobacco user rates, all things being equal. No medical underwriting, no pre-existing conditions. That is, right now, if you go on the most common kind of health insurance, a PPO plan, and they say, hey, if you haven't had coverage in the past and you've already got a knee issue, you've been seen and treated for it within the last 6 months, maybe you're taking a prescription or whatever, we don't have to cover anything related to your knee issue for the first 12 months of your coverage. That will be going away. So now, day one, whatever your issue is, no pre-existing condition exclusions. And again, guaranteed issue, they have to write the policy for you. There is some expectation that with large groups, the carriers do tend to track and run metrics on your overall claims data, and that may be something that they're able to use in determining ongoing rates for large group companies. Healthcare exchanges. I'll read it and then I'll tell you my 2 cents. Virtual insurance store, where individuals and small business will be able to purchase coverage directly from the carriers. Think of it like Travelocity for health insurance. It's a person or a small group, it's their ability to look in one place and see all the various carriers, see their plans, how they work, see the various rates out there. That's the whole concept of an exchange. It's pretty much the same thing. The only question is, what market does it serve? Individuals, small groups? It can be either set up and operated by the states if they so choose, but also the federal government does have their own exchange that they are building. In this case, in the individual market is the primary one that we're talking about. Arizona decided to let the feds just run it. They are not doing their own Arizona version, so they're defaulting to the government plan. There is a case out there, if you're following news articles and certain things. Oklahoma is being, maybe some would say, a little squirmy, trying to say, hey, based on the way you wrote this law, does that mean that we do or do not have to cover certain individuals, and therefore can we be exempt from elements of penalties and mandates and things? The reality is it's highly, highly unlikely that it'll ever have any traction, but it's out there if you're looking into case law. We talked about the different kinds of exchanges. Small business, also known as a shop plan, as well as individual Joe, the average person, can go and just sign up for a policy. And then there are what are called private exchanges, which means some third party has decided that, you know what, we can do this too. We can create an appropriate marketplace for people to come and find their policies, and it makes sense for us to facilitate and administer that. Actually, I've seen an article that Walmart is considering doing that. They have a huge workforce. Maybe they want to decide how everything works for them and for their employees, and then potentially be able to open up their system, their model, to other people who want to use that instead of, the federal or state versions. So we talked about, we'll just go over the small business or shop program quickly, because realistically, it has nowhere near the same number of regulations and consequences, timely penalties, as the individual side does. Individual side's going to happen. 2014, it will be live, but there's nothing to say that this small business option of an exchange has to exist, and not as much of timeline and consequences. So we'll see. But again, it's companies can buy group policies. Likely not able to be online when the individual side goes live. The insurance agent can still be, you can still use a broker, which we think is a pretty relevant thing given the ins and outs of how this whole program is working with all the fine points and the considerations that the average small business owner may not think to look into or to ask about. A couple of drawbacks that we already know about that may dissuade someone from using this kind of an exchange is that it sounds like they're going to be requiring your binder check, which is the money that you pay in advance to start your policy, to bind your policy. They're expecting that to be paid 90 days in advance of the start of your policy, and that they would expect you to also set up a recurring electronic bank draft so that it happens autopilot. Not everyone would necessarily be comfortable with that, so there will still be a lot of sorting out before everybody just hops on board and uses this option. Okay, individual. This is the first thing that has already changed. There was law saying that a notice has to go out to all employees of every company saying that, hey, guess what? In 2014, there's going to be this individual health exchange that you can go on to. And as of March 1st, you have to send the first letter drafted according to the Department of Labor template letter that they've got that says, here's what's coming. Well, they've already said Department of Labor doesn't even have that yet. We're not holding you to this time frame. It's at least months out. So it will be coming. Open enrollment for 2014 will begin in October, so that you'll have some months in advance to look at what do the policies look like and make your decision. If an individual buys a policy through the public exchange, they may be eligible for financial assistance. We'll talk about that more here in a little bit. You can go on the individual exchange even if your company offers a group plan. You don't like it. They offer Humana and you hate Humana? Okay, you can go to the exchange. So they will have online ways to do this, but there will also be these, quote, navigators who will have brick and mortar offices. So what's a navigator? It's just a person who is paid by the exchange to guide these individuals to their best coverage options. Very comparable to today's insurance agents, but they would be compensated by the exchange rather than by the insurance company. Okay, actuarial value. I'll read it through once, and I'll see if we can help you understand it in layman's terms. So for a given population, a big bunch of people, it's averages of their historical usage of the plan and the cost of that usage for all of the members, and then you break it down at the individual level, saying, an average person. It doesn't limit the cost as actuarial value. It's more just like, what do we expect based on average usage? The layman's term version is, you know there's going to be a certain amount of people who have a whole lot of costs and huge, hundreds of thousands of dollars in claims, and some people who hardly use it at all. So what they're really saying is, when you go out, you seek your health treatment, and you go to doctors, you get in lab tests, you're getting casts or whatever, how much does the plan pay for, and how much does the person actually have to pay for out of pocket? That's the actuarial value. How much does the plan pay for? So we have defaulted in 2014 to this, what they call the medal, kind of like Olympic medals, but the medal level, okay? We got platinum is the best, gold, silver, and bronze. It's almost like, back in grade school, A, B, C, D. So a platinum level with a little bit of variance, is about 90%. That for most of the claims that you're experiencing, if you're on a plan that's, quote, platinum, the plan ought to pay 90% of those costs, and you ought to be left with the remaining 10% as your out-of-pocket cost. And you'll see that it boils down to weaker and lesser coverage, the lower the actuarial value. Okay, so, and this is, everything that you're paying is figured into this actuarial value, like we said earlier, same with the max out-of-pockets. Subsidies and credits, similar concept, two different things. They are only available through the exchanges, through this individual exchange, okay? If you're an employee, your company offers you a plan that is a qualified plan, it has the essential benefits, it's not too expensive, it's a qualified plan. If that's available to you, you're not eligible for any of these subsidies, okay? Now, if, let's say your company offers it, but you're part-time, well, then you're not eligible. So then, yeah, you can get the subsidies if you go and you get an individual policy. If you are eligible for Medicaid, which Arizona recently said, yes, we're on board, we are going to accept up to 133% of the federal poverty line or the federal poverty level. If you're up to that earning amount, and it does, you'll see on the next slide, it's a scale depending on married, not married, kids, whatever. So 133%, you should be on Medicaid. It basically takes this out of the equation. So you got premium tax credits versus cost-sharing subsidies. The premium tax credits are reducing your premiums, how much you're actually paying to have the coverage, the amount per month, if you will. If you make lower amounts of money, up to, in this case, 4 times the federal poverty level, the government will pay some of the cost for your monthly premiums, okay? Here's the rough working numbers for 2012, so that if you're an individual, the federal poverty line is $10,800. If you make $10,800, well, you're going on Medicaid in that case, but let's say 4 times that, it's about 45 grand or 47 grand. So there are a lot of people who are fairly average wage earners who could be entitled to some government money to help reduce their cost of an individual program through the exchange, okay? All right, to figure this out, there's some math. The next slide will really explain it to say how do you get to what's it going to cost you, because they break it down on a sliding scale. Here's a sliding scale on the left-hand side. So depending on where you fall, let's say, you know, the example that we're going to borrow here, this is courtesy of Humana coming up in our example. Okay, this will give you the rest of what you're looking for. That wouldn't have made sense without this. Okay, so you can see if you are making a pretty good earning, you're between 300% and 400% of federal poverty level, you know, maybe around 40 grand, that the cost to you per month to have this plan will not exceed 9.5% of your income. That's your adjusted gross income, AGI, okay? If you're earning less and less, then the cost of health care as a percentage gets cheaper and cheaper as a percentage of your earnings. Here's an example of how it works. We're talking about a single person who makes $28,735 per year, and the magic number of where they determine the cost on this, I don't know how they came up with it, it's the second lowest priced silver plan. That's that 70% actuarial value. So let's say hypothetically that the second lowest silver plan costs $5,700 a year, okay? Little less than $500 per month, okay? And that the federal poverty level is about 11.4 as an estimation. So if you do this math, you've got someone's earnings times, if we look at that last slide, we see that at 250%, they are at 8.05%. That's the most that this insurance can cost them, is 8.5% of their adjusted gross income. So what is 8.05% of their adjusted gross income? Whoops. There we go. That means it's $2,313 is the most that they can pay. But the reality, like we said earlier, this plan actually costs $5,700. So the difference, the amount that the government is paying as a credit, essentially, is the $3,420. That's how much that the government is paying to reduce this person's monthly cost. Okay? Now, subsidies are different. And this doesn't go up to 400. It only goes up to 250%. But for very low income earners, they're saying not only do we understand that the cost of buying the health insurance might be prohibitive, so we're going to chip in some government money, they're saying the cost of actually using the plan, stuff like your copays, etc., could be cost prohibitive too. Maybe these guys can't drop, you know, a $20, $30, $40 copay here and there left and right. So what this does is it lowers the user cost when you actually go out and use the plan. The way that it works is it changes the required actuarial value for these brackets, okay? So let's say you make between 200 to 250% of the federal poverty level. Instead of that silver plan only covering about 70%, well, now it has to cover 73%. And if you're still a lower income earner, it has to cover 87 or 94%. If you're making, you know, 140% of the federal poverty level, you're above the Medicaid line, you're in this plan, the plan is going to be really super cheap, hardly anything out of pocket, and the plan has to pay 94% of your felt costs, meaning, you know, you get a $10,000 bill, you're left with 60 bucks. If I did that math right, 6%? Yeah. Okay. All right. Private exchanges. My big note or disclaimer on this is an evolving concept. We're still waiting to see what these private insurance exchanges are going to work like. I mentioned the Walmart example. You may hear a term called defined contribution. That is, okay, we're using this private exchange. Here are the plans that are available to you. We're going to define our contribution on your behalf. We're going to contribute $150 a month, whatever it is. That is your defined contribution. It's not the same as you're all just hopping on my group plan and here are the premium costs. It's basically, here's your $150. Go pick the insurance that you want based on the coverage level and the cost that meets your needs. But we expect to see more about that. But there would not be subsidies available through this private exchange. Another wrinkle, a consideration. All right, that brings me back to Kevin Steele, who will talk about the tricky and sometimes scary concept of pay or play, penalties, etc.
Do we have any questions right now on what's been covered so far before I...
How about general questions that just want...
There will be a bit of a recap later. I know we've blown through it pretty fast. And one of the reasons we're blowing through it pretty fast is because we would be here all day if we went through this in all the little details and gave you lots of examples and things like that. There will be a bit of a recap at the end. I know Tracy's got some comments to make about strategies, and she's going to make sure you understand how these work so that you understand the strategies.
We are trying to condense this because essentially between Hans and Kevin Steele and myself, I know I've personally done 2 or 3 in-person seminars plus ongoing webinars through the carriers or pretty much everybody who has their 2 cents that they want to make sure that maybe they want to keep the broker community happy. We're just kind of digesting a lot of different sources of information, trying to compile it in a user-friendly forum, and again, we're always available one-off if you want to talk about your own situation. Question?
Just one quick question.
Here, let me give you this.
As an employer, we pay 50% of the policy. How does that affect with what the government?
So she says right now, as an employer, they pay 50% of the policy, and a very common standard in health insurance is paying 50% of the cost of the plan for the least expensive available plan at the employee-only level. So then the question is, as an employer, is that math still going to work? And the answer is, it depends on how much your employees make, because it's really, as you see, Steele is going to talk about this, but it's bound by making sure that the policies that you offer are not, quote, too expensive for your less paid employees. So he can get into more of the details on that.
Yeah. Let me just expand on that for 1 second. It used to be, it was, okay, we're going to provide X amount for our employees, either it's a fixed amount or we're going to cover the individual cost at some percentage. All that is basically kind of out the window now, because now the benefits will be based on whether you're getting a bronze or a silver or a gold or a platinum. And then you have to look at, is it going to be affordable, and what do I have to give my employees in order to make it affordable for them? And we'll get into the penalties for having a plan that's not affordable. But instead of starting with, here's how much I'm willing to pay, now you're going to say, here's what I'm offering, how much is the premium, how much of that premium do I have to pay in order to avoid penalties from the federal government? And like I said, we'll talk about that later.
I have a small company with 2 to 3 full-time employees, at which time we don't pay any health insurance coverage. What impact do I have in the future?
Well, as we'll, right where I'm getting into right now, the pay or play part, you will find that you are exempt from any of the penalties. You will not be exempt from if you offer a health insurance plan, even if you don't pay for it, which you won't be required to pay for. You will have to offer essential health benefits. You won't be able to pick and choose what benefits they're in if it's a small group plan. So the carriers will only offer policies that have all the essential benefits in it. But if you are less than 50 full-time equivalents, which clearly you are not required to offer insurance. You're not required to pay for it if you do offer it. But if you do offer it, you have to offer a plan that has essential health benefits. So you might want to get up and leave. But there are a lot of, I'm just kidding, because there's a whole lot of things besides that. But you can probably, stop clenching your pencil quite as hard. Okay, so we're going to talk about the pay or play. This is the most controversial part and the most complicated part of healthcare reform. The good news is some people are exempt from it on the business level. The bad news is nobody is exempt from it on the personal level. So while you're sitting here thinking about your group health insurance, you also have to worry about the implications to you personally on your own insurance. As I just finished saying in answer to that question, small businesses or small employers which are less than 50 full-time equivalents are not subject to the pay or play provisions. So you can, listen, but, probably won't affect you if you're in that group. We're going to talk about large employers first. This is where you hear about all the real controversy. It's also referred to as the employer mandate. The government does not like the term employer mandate, so they use the term employer shared responsibility. Don't be fooled. It is a mandate. When we say pay or play, what do we mean? Well, technically, it means you either pay a penalty for failure to provide affordable coverage, or you provide an employee health insurance plan that provides minimum value benefits, which we'll talk about, to your full-time employees, only your full-time employees, that meet certain maximum cost requirements. So either you pay the penalty or you do what the government says, provide a health insurance plan, and you make sure that health insurance plan is sufficiently affordable that your employees who are full-time can afford it. Important point, I will use the term full-time equivalents and the term full-time employees. They are different. I have tried to make in the slides full-time equivalent initial capped FTE, and full-time employees I only initial cap the full-time. So it's a key distinction.
Could I interrupt you for a second?
Absolutely.
We own numerous companies, so our employee count goes way up if you put them all together. Is that going to be what it is, a blanket coverage?
I will, next slide. I may not have these slides in great order because I think that's liable to happen more than one time as we go through here. So 50 or more full-time equivalents during the measurement period. What's the measurement period? I'll explain that in a minute. What is a full-time equivalent? Normally you're used to thinking of a full-time equivalent as being 40 hours. For health insurance purposes, a lot of times it's 35 hours. So you say anyone who works 35 hours or more is eligible for health insurance with our company. That's kind of the break between full and part-time. For healthcare reform purposes, the break is at 30 hours a week. Not surprisingly, that means a whole lot more people qualify as a full-time equivalent. You do include PTO hours, so just because the guy didn't work for 2 weeks, if he got paid for it, those count as hours worked towards the 30. It excludes seasonal workers who work under 120 days a year. Now, Tracy actually has a slide I know that goes into more detail as to what constitutes a seasonal employee. But if you have a seasonal employee, you better be sure they qualify as seasonal, because the government doesn't have a great definition of seasonal. There's some guidelines you can use, but if you guess wrong and you say this guy's seasonal, but he really isn't, maybe you're just busier in the summer than you are other times of the year, that doesn't make him a seasonal employee. If you decide I'm going to exclude him because he's seasonal, government comes in and says no, he's not seasonal, suddenly that puts you from 40 full-time equivalents to 60 full-time equivalents. You've got a big problem because there's big penalties associated with not offering insurance if you're over 50. So be very careful with this seasonal employee exception. I strongly recommend you get your legal counsel to buy off on your definition of seasonal unless it's really obvious. Variable hour employees are employees who work or may work less than 30 hours a week. They count as a fraction of a full-time equivalent. That's just your full-time equivalent thing. If you have 2 employees and they each work 20 hours a week, normally you'd say, well, I have 1 full-time equivalent because there's only 1 there at a time. And they each work 20 hours. Well, under healthcare reform, you have 1 1/3 full-time equivalents because they each count as 2/3 because they each work 20, which is 2/3 of 30. So it drives the full-time equivalent numbers up because they used a low level of 30 full-time equivalents. And we're just the messenger, but you just have to take my word for it. If you have 2 employees and they each work half-time, you have 1 1/3 full-time equivalents.
Steele, if I can interject real quick, I happen to know Kevin Steele comes from an accounting background and is really good at these numbers. So if you're wondering or nervously anticipating how on earth am I going to determine this, if you're already running payroll through us, we likely have some reports that we can run to give you a real good barometer of where you're likely to land, and certainly can help guide our customers through whether or not these are full-time equivalent employees and how many does the count actually add up to.
If you're really cynical, you think the whole point of this is to get you guys so scared that you say, I better have these guys handle it because they handle that for their clients. But it didn't occur to me until just now. We have a question.
You're talking full-time equivalents versus full-time employees. So a full-time equivalent, we're calculating based on 30 hours. But does that mean we have to consider full-time employees now being 30 hours or more by government standards?
Well, just for the purpose of healthcare reform, yes. And I'll show you some examples of that later. But I mean, you can, for whatever other reason you want, you can use 40 hours. But for purposes of determining whether you're a large employer, it's 30 hours. And then when it comes time to offer insurance to your full-time employees, it's also 30 hours. But I jump ahead. What if you have an employee that's only been there for a month? You don't know how many hours he's going to work for sure. Or maybe you do know how many hours he's going to work for sure. If you know he's going to work more than 30 hours, or she, regularly, generally speaking, they are a full-time employee. So they would count as 1 full-time equivalent. And I'll show you in that example when I get there. Okay, common law employer. This is a very key point. Some people think they can hire from a PEO, for instance, and avoid all these requirements because then they have no employees. That does not work for healthcare reform. The common law employer is the employer who benefits from the work that is done by the employer, by the employee. It's the person who directs the employee, that controls the employee, tells them what to do, tells them when to be there. In all cases, at least for national PEO, that is the client. So very important point. There may be instances where you do use contractors or you believe them to be contractors, and they may actually be employees. You may use temporary people. They may actually qualify as employees under the common law employer definition. If you get into those kind of instances, give us a call, give your attorney a call, get a interpretation of what he or she thinks that really is. Just a sec. Were you giving me the 5-minute notice, or you need a change? Yeah, about 7 minutes. Okay. Sorry, so I don't want to run over the tape capacity. Okay, so this goes to the earlier question of I've got a whole bunch of companies. Do I have to add them together? The answer is possibly. The rules for who is an employer are based on the Internal Revenue Code Section 414 B, C, and D. Basically, to summarize, and this is where we are not giving legal advice because this is a very complicated subject, and you may need to speak with your tax accountant because if you have any kind of a complicated tax situation, they would have to go through and make a calculation of who is in your control group to allocate tax attributes or whatever you may have in your tax returns. Generally, it's 80% direct or indirect ownership. Now, it also includes affiliated service groups, and there is a lot of leeway for the government to be able to decide, well, okay, so you own 79%, but 100% of this company's business is really integral to your business. They're going to include that in your controlled group. Because it's so circumstance specific, we don't tell you that, and because it's highly technical tax stuff, we expect you to get that information from your tax accountant. But if you own more than 80%, you can just, I'll guarantee you they're in your control group. Affiliated service groups, if you know what those are, if it's an affiliated service group, it's going to count as part of your control group as well. It's not going to get you out of it. Seek assistance with your tax accountant. That should have been in all capital letters. A control group for purposes of healthcare reform is what's called an applicable large employer. You can have a dozen members in your group, like you say you have multiple companies. Not all the companies have to pay or play the same. You can have some that pay and some that play, if that makes sense to you for some reason, if that somehow works out better. However, as I get to later, you get 30 free employees if you don't offer health insurance. You have to allocate those 30 employees to the various members. So you can't load up all 30 on one company and say, okay, they only have 30 employees, they're all free. You have to allocate them out, so you can't get around it. I can tell you that the healthcare reform also has provisions in it that says anything you do to try and avoid complying with healthcare reform, you can't do it. So if you want to, got a lot of clever ideas of how you can get around some of these limits and things like that, the government says if you're doing it for the purpose of avoiding liability under healthcare reform, by definition, it's illegal. So what is the measurement period to which I alluded earlier, where you have to count your number of full-time equivalents? Well, just to make things a little more complicated, there are two measurement periods, the standard measurement period and the initial measurement period. To make it easier, you can ignore the initial measurement period for purposes of this discussion. I'll touch on it later, but the measurement period we're talking about is the standard measurement period. It is the period of time beginning with the effective date of when you have to comply with healthcare reform. If you are a calendar year health insurance plan, assuming you have a health insurance plan, then you have to adopt on January 1st, 2014. If you have an existing policy that renews on April 1st, you don't have to do any of this until April 1st. So that was a fairly recent change that a lot of people were happy to hear. If you have a December 1st policy, you get a whole extra 11 months to comply with the law. So you start with the effective date, whatever that is for you, and you count backwards anywhere from 3 to 12 months, whatever you want to do. Now, why would they do that? Well, sometimes it'll look really bad for you because you have a high concentration of employees towards the end of the year, say. If that's not good for you, then you go out to a 12-month period or a 6-month period. You could try every combination of dates in there you like and find the one that helps you the most. Keep in mind, this is an annual calculation, so whatever date you pick, that's not that you can't change from year to year. I don't really know the rules on when you can change and when you can't change, but you'll have to do this calculation and measurement period every year. So it's not just a one-time thing the first time you implement. We'll talk a little bit later about why you might want to go with one period versus the other. An exception, if you happen to be a January 1st plan, and therefore you have to adopt early, the government say, yeah, we realize it's really unfair for you guys because we don't even have all the rules out yet, and we're asking you to comply on what is essentially short notice. So we're going to cut you some slack. If you're a calendar year plan, you can pick any 6-month period in 2013, so long as it doesn't start later than July 1st, which of course it wouldn't be in 2013 if it started later than July 1st, and ending no earlier than 90 days prior to the implementation date. You can forget that last part for now. That's another thing that's kind of like overkill. Also, something called the stability period. I'll talk a little bit more about that later, but even if you take this exception on the end and say I'm a calendar year company, but I'm going to pick 6 months in 2013, you can still use a 12-month stability period.
We're going to swap tapes right now.
Okay.
We're going to swap tapes, which gives me about 20 seconds, not to derail your thought, because we're still talking about the measurement and stability periods, remembering in common language, that is